Well, hello everyone. Welcome again. Thank you for joining us for today's national webinar and congressional briefing, The Role of Federal Agencies in Supporting Women's Bone Health Early and Often, a Policy Imperative. My name is Katie Schubert. I'm President and CEO of the Society for Women's Health Research, or SWHR. And SWHR would first like to thank the sponsors of our 2023 Bone Health Program, Amgen and UCB. We appreciate the contributions of these organizations for making today's event and our programming in bone health possible. Before we get into today's program, I want to review just a few housekeeping notes. Please note that today's web event is being recorded. It will be posted online. We will also send out the recording and any resources mentioned in the follow-up email to registrants. To ask a question to the panelists during this event, please use the Zoom Q&A function. You could alternatively use the chat function, and we will ask questions at the end of the event following all panelists' presentations. If you do need technical assistance, please write that in the chat function, but note that we do have limited technical assistance available while the webinar is running. So SWHR is a more than 30-year-old national nonprofit dedicated to promoting research in sex differences in disease and improving women's health through science, policy, and education. And we've been actively working in bone health over the past several years. Women account for 80% of the estimated 10 million Americans with osteoporosis and have a greater risk lifetime of fracture. In April 2022, SWHR convened an interdisciplinary working group to discuss scientific and policy issues in women's bone health, which resulted in a variety of resources, a report in the Journal of Women's Health, a bone health policy agenda outlining steps that can be taken to improve the bone health of women across the lifespan, and a joint congressional briefing with the Bone Health and Osteoporosis Foundation and the American Society for Bone and Mineral Research on osteoporosis and its impact on women in society. And speaking of BHOF, I would like to make a plug for the congressional briefing they just hosted last week, Women's Bone Health Throughout the Lifespan, that covered the bone health crisis in the US and steps that can be taken to protect bone health overall. And that recording is posted online. So we're looking forward to building on SWHR's past work in bone health and supporting the future work here and continuing the momentum from BHOF's event last week and during today's event. And so at this time, I would like to introduce Lindsay Miltenberger, SWHR's Chief Advocacy Officer, who's moderating today's event.
Thank you, Katie, and thank you all for being here. SWHR is honored to be joined by representatives from some of our nation's major research and public health agencies. Each day, the work of these organizations is helping to ensure that Americans live safer and healthier lives. We are so grateful that they have agreed to share their time and their expertise with us and to share specifically how they are working to drive improvements in women's bone health across the lifespan. So with that, I'd like to introduce our speakers. Dr. Beth Collins-Sharp is a health scientist in the U.S. Department of Health and Human Services, Office on Women's Health. Previously, Dr. Collins-Sharp was with the Agency for Healthcare Research and Quality in roles including Senior Advisor for Nursing and Director of the Evidence-Based Practice Centers Program. Before joining federal service, Dr. Collins-Sharp served on the faculty of the Medical University of South Carolina's College of Medicine and as Director of Research for the Obstetrics and Gynecology Department. Gage Dalton is a public health analyst in the Division of Policy and Performance Management in the HHS Office of Women's Health. Prior to his role, he worked as a paramedic, serving primarily rural populations while he completed his graduate coursework focusing on healthy behaviors. Dr. Daniel Green is a board-certified OBGYN and is a medical officer at CMS in the Quality Measurement Value-Based Incentive Group, serving as the quality team lead and the registry and qualified clinical data registry lead for the Merit-Based Incentive Program. At CMS, Dr. Green also works on measure development, health equity, and projects related to women's health care. Dr. Lyndon Joseph is an exercise physiologist and is a program officer at the National Institute on Aging's Division of Geriatrics and Clinical Gerontology. Before joining the NIA team, Dr. Joseph was an assistant professor in the Division of Gerontology in the Department of Medicine at the University of Maryland, Baltimore, with a joint research fellow appointment in the Geriatric Research, Education, and Clinical Center at the Baltimore Veterans Affairs Medical Center. Dr. Ruth Peterson, last but not least, serves as the director of the Centers for Disease Control and Prevention's Division of Nutrition, Physical Activity, and Obesity, which provides national leadership on nutrition, physical activity, and obesity prevention through policy and guideline development, surveillance, epidemiological and behavioral research, and technical assistance to states and communities. Dr. Peterson's experience and leadership spans healthcare, local and state health departments, national advisory groups, academic settings, the private sector, and global health platforms, and her experiences have helped the division in its efforts to prevent chronic diseases and strengthen equity and well-being. Thank you all again for being here today. We're so grateful to have you and to hear directly from you about your agency's work in women's bone health. So with that, I would like to transition to our first speaker of the day, Dr. Lyndon Joseph, who will talk to us about NIA's portfolio on bone health. So Dr. Johnson, I will stop sharing and I will turn it over to you. Dr. Joseph, do we have you on?
Yes, I'm just putting up my screen.
Okay, perfect.
Sorry about that. Just give me 1 second. My apologies there. Okay, can everybody see my screen? Okay, can everybody hear me? Hello?
We can hear you.
Okay, good morning, everyone. As you just heard, my name is Lyndon Joseph from the National Institute on Aging, and our mission is to improve the health and quality of life of all the individuals, and we do that by supporting research through 4 different divisions: the Division of Aging Biology, which support molecular cell and genetic research; the Division of Behavioral and Social Research, which supports social and behavioral research on aging; the Division of Geriatric and Clinical Gerontology, which is my branch, looks at translational research on health and disease of the aged and issues across the lifespan; and the Division of Neuroscience, which try to understand neural and behavioral processes with the aging brain. And of course, we are the federal agencies looking at research on Alzheimer's disease. So what I want to show you here is basically what the NIA has been doing on bone health over the last couple of years. And this graph is actually showing you a current active grants that are looking at bone health. And the figure on the left shows you that there are various areas that have been studied, all the way from stem cells to long-term studies to looking at bone marrow, senescent cells, and then specifically focus on the older adults. And we have a small study on Alzheimer's, looking at the relationship between Alzheimer's and bone disease. But I just want to show that some of the topics that these grants try to address is looking at studies at risk factors, intervention studies to prevent bone loss, intervention studies, both pharmacologic and non-pharmacologic, to look at to prevent fracture and improve functions. And of course, there's a host of preclinical mechanistic studies on bone quality, looking to anything from fracture repair to osteocyte, osteoblast biology, stem cells, microbiome, the microarchitecture, bone modeling and signaling, epigenetics, the role of circadian clocks, and omics, and how that affects bone health, bone quality, and bone integrity. But what I want to do for the next couple of slides is that, since this is looking at bone health, is just to highlight a few studies that NIA, along with other NIH agencies, have funded some longitudinal studies over the years. And the first one, as I want to point out, is 2 longitudinal studies looking at osteoporosis. The first one is the study of osteoporosis in women, which is called SOF. And I have to also let you know that we also have companion study looking at osteoporosis in men as well. But these studies have looked at over 9,000 women and men over the years, over 65 years of old, what risk for hip fractures, and they followed them for many years to look at different risk factors and different outcomes related to the hip fracture. But what I want to show you here is just this one graph looking at bone mineral density, and you can see that people with the lowest bone mineral density have a higher risk of hip fracture over the years, starting from the lowest quartile to the highest quartile. And as they go out in years, once diagnosed with osteoporosis or low bone mass, bone density, you can see that the hip fracture rate increases exponentially. Other studies that have been done through the SOF, important discoveries have shown that the BMD is a good predictor of hip fracture for greater than 20 years, and hip fracture is the strongest predictor. A lot of you might have heard of the FRAX index, but they use data from the SOF to come up with these predictive factors. Data from the SOF is also used to sponsor the first clinical trial on bisphosphonate and how it affects improve bone health after hip fracture, and the study was done with allangenate. They've identified several biomarkers for hip fracture, and one of the first studies identified that ApoE genetic, there's a genetic component to hip fracture as well. And we not only study hip fracture, as I mentioned, but other physiologic and biologic variables, and the last two bullets show you that people with women with high physical activity levels over the years are likely to have a decrease in cognitive decline after 6 to 8 year follow-up. And less sleep and O2 desaturation increases dementia and death as well in these individuals. So the SOF study not only look at bone, but also look at other important variables for the health of women as they age. The next study I want to highlight is the study of women's health across the nation, SWAN. This study was designed to look at the menopausal transition and look at the physiologic and biologic changes across the menopausal transition and how it affects women's health. As you can see, there are various outcomes that were measured here, but in the middle is the bone. And I just want to show you that this study started back in 1994. They enrolled around 3,000 women. And because of the effect of minority status on bone health, they made a concerted effort to increase the enrollment for minorities. So they had African Americans, Japanese, Chinese, Hispanic, and Caucasians. And just to highlight a few studies that they have shown is that, for one, between Caucasian and African American women, the microarchitecture of bone, when you're talking about the trabecular cortical thickness, was greater in African Americans compared to Caucasians. But the thickness alone does not always count, but they showed that the stiffness and the failure load of these bones were also significantly greater in African-American women. The third bullet shows that the decline in bone mineral density over the menopausal transition was smaller in Blacks than in whites. In Chinese and Japanese women, they have low premenopausal bone mineral density, but also have larger percentage declines in bone mineral. So it shows that there is some sort of ethnic difference in bone biology as women age, and the difference in the cortical thickness and the strength could account for the lower fracture risk in African Americans. Another major study that we funded over the years, we started back in 1983, is the Baltimore hip fracture study. And over the years, they've studied over 3,000 hip fracture patients from 25 different area hospitals, and looking at outcome of mortality, functional recovery, change in bone mineral density, bone mass, muscle mass, and composition. And the goal was really to identify and develop strategies to optimize recovery from hip fracture. I just want to show you highlight a few outcomes from the study and show that there's a sex difference in survival after hip fracture. But irrespective of the sex difference, you can see that a significant amount of these patients die in 2 years after experiencing a hip fracture. For male, it's up to 58%, and for women, it's up to 77%. And the ironic thing about this is that these studies have found that most of these individuals do not leave the hospital with therapy, whether or not it's bisphosphonate or not. And so that was alarming from this finding. This study also found changes in cognitive factors, depression, physical activity, and activities of daily living after hip fracture. What this slide is showing you that from this initial study, we have branched off the various domains in the hip fracture literature. Starting from the top, looking at the consequences of hip fracture, going down to hip fracture 2, looking at determinants of fracture recovery, then looking at bone and muscle mass changes following hip fracture. And if you follow that yellow box to the right, it looked at bone and muscle interaction after 1 year of hip fracture, changes in insulin growth factors, bone histology, changes in bone fracture metabolism, the effect of vitamin D and on function post-hip fracture, the effect of inflammation, and also how do exercise interventions, whether or not it's strength training or task-specific training, how does it affect recovery after hip fracture? And so this study went on for quite some time. It just recently ended, but it has identified some seminal findings with hip fracture, post-hip fracture in individuals, both men and women. So because of I just mentioned earlier that most of these people with hip fracture or in osteoporosis are not on medications. And one of the reasons is that there have been some issues related to adverse events, which is osteonecrosis of the jaw and atypical femur fracture. And so we wanted to dig deeper into that. And so back in 2018, NIA partnered up with NIAMS, which is National Institute of Arthritis Musculoskeletal Disease, to have a workshop to figure out, to identify the use of osteoporotic, the appropriate use of osteoporotic drugs and the risk to benefit ratio. And as you can see from the right, we have published some systematic review on the evidence, the workshop panel report, and an editorial. And what that does is identifies some gaps in research that we intend to examine over the coming years, to fill these gaps and really try to figure out the risk-benefit ratio of being on osteoporosis drugs. So to date, what we have done, we have published 2 program announcements looking for research. The top one is looking to use large database to better understand the risk-benefit ratio of long-term osteoporosis. And the goal was just to provide an appropriate strategies for long-term therapy, including whether or not drug holidays is important, or to better understanding the risk and benefits, and not only drug holidays, different types of treatment plans as well. The second side, which is noticed down there, is we done this in combination with NIAMS. And what we're trying to figure out is understanding the pathology and the pathogenesis leading to these atypical femur fracture and osteonecrosis of the jaw when these patients are on these bone medications, in the hope that the trend that we've noticed, which is the decrease in use and the ticking up of osteoporosis, which has been going on for many years, whether or not it's the adverse events that are driving the patient-doctor interaction to prescribe and to use these drugs. And so those are the studies that we've been doing so far. But I just wanted to highlight this last slide here, which shows that not only NIA is the only institute that's really looking at bone health, but as you can see from the slide on the left, NIDDK, NCI, especially related to cancer and bone metabolism. NHLBI didn't show up, NIAMS. So many of the 27 institutes and centers of the National Institute on Aging is looking at bone health and women issues as it relates to health and quality of life. And the slide on the right is pretty similar to the slide that I just showed you. It's just an expanded version showing that, they're looking at clinical trials, mechanistic studies, looking at bone marrow, stem cell, and immune functions and how it affects bone health. And of course, there's a lot of studies looking at older individuals when we're looking at the interaction between bone and muscle, cell function, falls and fracture, and cognition. And with that, I'd like to say thank you very much for allowing me this time to speak with you. And here's some links to find out more about funding and the latest approved concepts and the blog for NIA. Thank you so much.
Thank you so much, Dr. Joseph. I know we gave you a big charge to try to cover NIA's bone health portfolio in a short period of time. We really appreciate you reviewing that with us. At this time, I would like to turn it over to Dr. Peterson to discuss some of how CDC is supporting women's bone health across the lifespan. And Dr. Peterson, I will get your slides pulled up now.
Great. Thank you, Lindsay, and welcome to all of you. This is a very important topic that CDC is committed to. I'd like to have the pleasure today to share with you CDC's work supporting bone health. And the subtitle on this, when you see the slide, is Early, Often, and Holistically. So that's what we're going to cover in the next few minutes. Specifically, I want to talk to you about, the second slide, Lindsay, how CDC supports bone health across the lifespan, and also share with you some bone health resources and strategies by life stage. Next slide. And this just reiterates how important this is around the life course perspective for us. And the next slide shows you our strategic priorities that we have in the Division of Nutrition, Physical Activity, and Obesity, where we really aim to reach all Americans across the lifespan by supporting this healthy start for infants, having children and youth growing up strong and healthy, and then helping adults and older adults maintain a healthy lifestyle. And bone health is woven into all of these things. I won't go through all of our priority areas, but they're in the boxes below, which really gives you a sense of the depth of our portfolio in promoting health across the country. And all of these topics influence women's and men's bone health into the future. So next slide, please. When you look at our portfolio, which again, given our name of our division is Nutrition and Physical Activity and Obesity Prevention, I want to share with you a more granular vision of what optimal nutrition looks like across the lifespan in our work. So we are really working to establish healthier food environments for all, including, as you see, maternal nutrition, all the way through early care and education and family healthy weight programs for children, and then into older adults and all populations for healthy food systems. Please note at the bottom of that, the green bar, which is health equity. We embed health equity into all of our work, which for our purposes means that we track health disparities, and then we work to reduce those disparities with specific interventions and programmatic work that will lessen those disparities across the country. Next slide. This is a similar graph for our physical activity work, which again will promote bone health. And we work with communities and states to equitably integrate physical activity for all, including, again, in settings from early care and education to safe routes to school, but then also in the community. So we really want communities designed to promote the ability for safe and convenient physical activity, again, for those populations that are disproportionately affected by chronic disease and obesity and other issues that would be related to bone health overall. Next slide. I want to give you just a snapshot of how we do our work at CDC, and that is through our funded recipients. We have 3 lines of funding that go out to fund our program work across the country. We fund state health departments or their designees through what we call our State Physical Activity and Nutrition Program, or SPAN. Those are the teal colored states on this map. We currently have just started a 5-year funding announcement to 17 health departments across the country that you see here to promote nutrition and accessible physical activity and breastfeeding. We also have the High Obesity Program, which is a congressional line item that we get for funding to go to land-grant universities where obesity rates are over 40% in particular areas. So you see those sort of orange pens there for where we have land-grant universities who are working in communities where those in counties where there's a self-reported rate of adult obesity of over 40%. So imagine the impact that has on bone health as well. And we also have the racial and ethnic approaches to community health that many of you may have heard of. These are 41 funded recipients across the country who are working on addressing health disparities among racial and ethnic populations with the highest risk or burden of chronic disease. Next slide. So again, I want to talk about now in closing, in the closing session, about bone health resources and strategies by the life stage. Next slide. So this, I hope people are familiar with the Dietary Guidelines for Americans. We are currently enjoying the 2020 to 2025 guidelines. That is a great resource for nutrition information that supports optimal health, including bone health. So the DGAs, as we call them, contain nutritional recommendations by age and by life stage to help everyone eat healthier and maintain good bone health. And one of the key recommendations from the DGAs is to focus diet on nutrient-dense foods and beverages that provide vitamins and minerals for good bone health. So this is very important, and it should shape, not only it shapes all of what we do in food service guideline implementation, procurement strategies across this country. It is an incredible resource if you're not aware of it. Next slide, please. So similar to the dietary guidelines for Americans, we also have the physical activity guidelines for Americans. And this provides recommendations for physical activity, again, by age and life stage. And you all know on this phone call and this webinar that what we need to do is have regular physical activity built in to everyone's life, because it's so important for strengthening bones and avoiding fractures. One of the key recommendations from the physical activity guidelines for older adults in particular is to introduce balance activities into regular physical activity to reduce the risk of falls that may lead to fractures. So again, I hope everyone has this as a resource. It's critical work. It can range across the lifespan. It has recommendations for the lifespan, and it drives our work in the communities where we fund states and communities to improve access to safe and convenient physical activity. Next slide, please. I also want to point out our infant and toddler nutrition web pages. This is very new scientific information that, again, we've been able to cull because of the work of the Dietary Guidelines for Americans at this important time frame for nutrition. So please keep in mind that nutrition patterns are established early in a child's life. So the habits that they get and the taste that they develop for liking or not liking are generally developed in those first few months to years of life. So we really look at the first 1,000 days of an individual's life, including the pregnancy and the birth, and then up to 2 years of age, being critical in setting the stage for long-term health, including bone health. So we're very pleased to have new information on our web pages that give information to caregivers and to providers about how they can improve the nutrition quality of their young child, because there's a lot of information that we need to continue to share across this country. Next slide. I also want to give you a little bit of information around our very exciting communications platform that we have called Moving Matters. So this is a physical activity campaign that is tied to our effort around Active People Healthy Nation, which is an initiative we have at CDC with many, many, many partners to look at how to improve physical activity among Americans for 27 million more Americans by the year 2027. So this doesn't mean that everyone has to meet the guidelines. It means that people should improve their physical activity. And this is so important because some people, even those little changes, make a huge difference in their health and health status. So if people aren't able to meet the recommended 150 minutes a week, depending on their age and their muscle strengthening work, even little amounts of physical activity will have a huge impact on people's health. And we even have data to show that even for people who are not physically active at all, even 10 minutes a week can improve their health outcomes. Next slide, please. So I want to make sure that you have a slide about our online resources. We have data from states. We have our State and Community Media Center, which actually has the Moving Matters materials on it. We have our website. And then next slide, please. I also want to share with you how to get regular updates from us. So please scan this code and you can enter your email to sign up to get our notes from our division, including our research roundup and including our insider networking, which actually has news that will be relevant to bone health that will help all of you in the future. So thank you very much for the time, and I look forward to hearing from the rest of the panel and then answering questions at the end.
Thank you, Dr. Peterson. And I really appreciated you focusing on the lifespan within your slides. I think, when it comes to bone health, so often it's not thought about until someone experiences a fracture, but the steps that people take early on can really have a direct impact on bone health across the lifespan. So I want to thank you for that. I would also like to remind our audience that if you have questions for our panelists, please use the Q&A function and we'll make sure to get to as many as we can at the end of today's webinar. With that, I would like to transition to Dr. Green with the Centers for Medicare and Medicaid Services to talk about how CMS is supporting this work. So Dr. Green, if you will give me one moment, I'll get your slides pulled up and you can get started.
Sounds great. Thanks, Lindsay. While you're doing that, I just want to thank the Society of Women's Health Research for hosting this program today. Osteoporosis, as you probably gathered, is underdiagnosed, and there are a lot of things we can do to prevent the unfortunate outcomes that can be associated with it. So thank you all. So if we could go to the next slide, please. All right, this is just the typical CMS disclaimer. I'm not going to spend any time on it. Next slide, please. So in the next few minutes, what I hope to provide you is an overview of some of the programs, activities, and services that CMS provides or is involved with as it relates to bone health. This would include prevention, detection, and treatment. Next slide, please. Okay, so you all may know this, or maybe you don't, but CMS is the largest single payer of healthcare, or purchaser rather of healthcare in the United States. We are trying to transition Medicare from a traditional fee for service. So, you see your doctor, the doctor gets paid, and that's that, to a value-based care reimbursement system. So obviously you see your doctor, but we also look at the quality of care the doctor's providing and at what cost. And we put all that together, and we're working toward transitioning some of the payment, if you will, for Medicare. We provide coverage to over 130 million people, basically 1 out of every 3 Americans. 64 million are enrolled in Medicare and about 75 million in Medicaid. There are what we call dual eligibles, which would be 12 million and would include 12 million folks who are enrolled in both programs. As you probably know, most Medicare bennies are over age 65. In fact, that accounts for 80% or more of our beneficiaries. And over half of our beneficiaries are women. Next slide, please. Okay, so this is a nice and complicated slide. I always love that when I'm in the audience. So basically, a big thing that we do, and certainly something that I work on every day, is measuring quality, and the quality of care that patients receive. We do, again, as I mentioned earlier, try to incentivize providers to provide the right care, obviously for the right patient at the right time. So we do try to focus our work on prevention, treatment, and using this data. And if you look at these circles that contain the circles that are in blue, you can see the clinical standards. This is the center that I work in, and we provide quality and safety oversight, as well as quality and public reporting. So reporting to the public some of the data that we get on the quality of care that clinicians are providing to their patients. And of course, these yellow circles basically have to do with some of the other programs and functions that CMS works on or is in charge of. Next slide, please. Okay, so this next slide looks at our national quality strategy goals. And you can see that we leverage a number of approaches to improve healthcare across the country. Quality measurement, of course, is one of the things that we do. Public reporting, and again, that's making the data from the quality metrics that we look at available to patients and businesses, if you will, so that they can decide, hey, we think this practice provides better care for the condition that I have, so I'm going to try to see a provider in that practice, as an example. Again, value-based incentive programs, again, looking at high quality, low cost and hopefully with good outcomes to reward clinicians who are participating and practicing in that way. Obviously enforcing health and safety standards, so we don't want anybody cutting corners, and risking or compromising patient care. And then we do try to engage patients, stakeholders, and others to drive innovation, foster excellence. We are very interested in advancing equity. We have a whole program, not specifically related to bone health, but in general for our quality metrics, looking at providing equitable care, and then, of course, expanding access. Next slide, please. So the prevalence of osteoporosis in our population. So you can see from the slide, 6.6% of all fee-for-service, so that would be like Part B Medicare beneficiaries, had a diagnosis of osteoporosis in 2018. Again, as I talked about earlier, most of the patients in Medicare, over 80%, are over age 65. And no surprise here, there's a higher prevalence rate among those over 65 compared to those beneficiaries that are less than 65. Of course, females were more affected than men. Part of that has to do with the bone mass that men have going into later in life. Women have typically have a smaller bone mass as they enter menopause and then as they continue to age. Next slide, please. So this slide just is a busy slide, but it's colorful, is a graph of kind of what I just mentioned. You can see where the arrow is. Osteoporosis affects 6% of our beneficiaries, but you can see that there are often multiple comorbidities with these folks. So, another 27% of them had 1 to 2 other comorbid conditions, and you can see going along the graph. Up 37% had 5 or other health problems. So it's these patients, some of them, again, just have osteoporosis, but most of them have other conditions, which of course can make not only treating them, but more importantly, if they suffer a fracture, can make their treatment much more difficult and much riskier. So it's important that we work on prevention. Next slide, please. So we do have multiple services to prevent and treat bone health related issues, including DEXA screening, medication, physical therapy. DEXA screening is covered at 100% when medically indicated. We do cover 80% of the cost for treating osteoporosis, including physical therapy and medications if the patient has Part D. Next slide, please. Okay, so these are some of the criteria for which we will cover bone density or bone mineral density. And you can see that the bone density is covered every 2 years, and this would include folks with vertebral abnormalities, estrogen deficiency, who are at increased risk for osteoporosis, folks who are going to receive steroids for more than 3 months, a diagnosis of primary hyperparathyroidism, and if folks are taking FDA-approved osteoporosis drug therapy, such as the bisphosphonates or rank ligand inhibitors, follow-up bone testing would be covered for those folks as well. Next slide, please. I'm going to just transition and finish up with the last couple slides in terms of the quality aspect, which is what I work on mostly. Why should we bother measuring quality? When you go see your doctor, you're expecting her or him to obviously provide you good quality care. And I'm sure that's the intent of clinicians that are practicing, but unfortunately, in today's busy world, that doesn't always happen. So our quality measures sometimes look at the guidelines and sometimes go beyond the guidelines and standards to try to look for areas where we can improve quality and hopefully, in this case, prevent bone fracture. If we don't measure how people are actually performing on these quality metrics, we don't know if there's an opportunity for improvement or just in general how they're doing. So it does allow us a method to understand the performance. Again, we're looking for patients, we're looking for clinicians to provide quality care to their patients. So for example, if they're 65 and they haven't had a DEXA scan previously, and they're a woman, we do, want that clinician to order a DEXA scan for that patient. It's one of the recommended guidelines, and we have a quality metric, which you'll see in a second, which actually looks at percentage of patients 65 and older who received the DEXA scan. And then, as an added incentive, the old carrot and stick, we link payment not specifically to whether or not a clinician ordered a DEXA scan, but to a group of quality measures, how well the clinician did compared to their peers. We also look at costs. We look at quality improvement activities. And of course, we do have a component of our MIPS program, measure-based incentive program, that includes adoption and use of electronic health records. Next slide, please. So the last slide here basically just shows the measures that are available in our quality reporting. Where it says MIPS number, these are measures that are available to any clinician who is reporting or participating in the MIPS program. The QCDR stands for Qualified Clinical Data Registry, and these are specialty societies or organizations that have measure development experience and have self-nominated to participate and report on behalf of their clinicians to our program. They're allowed to create their own measures, and the measures are reviewed by CMS, and if appropriate, are used in the program. Again, not for just anybody, but for folks that are reporting via that mechanism, which in this case is the Clinical Quality Data Registry. And last slide, please. This slide just lists some of the preventive services that are available for our female beneficiaries. You can see bone density is highlighted at the top. And I think, we do one more slide, I'm sorry. This is just a couple links if folks have questions and want to receive additional information. Thank you very much for allowing me to participate today.
Fantastic. Thank you so much. A lot of good information there. Particularly appreciated your slides on why we measure quality, and then also the graphic on multiple chronic conditions and how that compares for people with osteoporosis. I think that really makes a compelling case and puts some of this into context. Our final speakers today are with the U.S. Department of Health and Human Services. So I am pleased to invite Gage Dalton and Beth Collins Sharp to present. Thank you both for being here. And Dr. Sharp, do we have you?
Here we are. Thank you.
Perfect.
My menu moved. Hello, everyone. Greetings from the Office on Women's Health. We are located within the U.S. Department of Health and Human Services, Office of the Assistant Secretary for Health. The office works towards our vision by providing national leadership and coordination to improve the health of women and girls through policy, education, and innovative programs, which are reflected through 4 goals. The Office on Women's Health has an extensive portfolio that we coordinate across HHS with other departments and with the White House. We often connect topics, for example, maternal health and mental health, breastfeeding and equity, violence against women, and substance use disorders. Here you can see how to connect with us, because we also leverage our strong online presence, especially for our signature observances like National Women's Health Week in May and our campaigns. And this brings us to today's topic. We are hoping to expand your worldview of bone health by including muscle health. Strong bones and strong muscles are connected, both literally and figuratively. If you have strong bones and fall, you have a lower risk of fracture. But if you have strong muscles, you may not fall in the first place. Therefore, we would like to introduce you to sarcopenia. Sarcopenia is the loss of muscle and strength that happens when someone gets older and has less physical activity. This affects at least 10 to 20% of older adults, and of course, then impacts activities of daily living and also increased rates of falling and fractures. We first started talking about sarcopenia as the pandemic ended and thought about the impact of decreased activity. Loss of muscle strength is an important impact that hadn't really been considered before. More so, recent reviews have shown that knowledge of sarcopenia is limited. Therefore, we have developed a campaign called Stronger Than Sarcopenia, which will increase awareness of sarcopenia among target audiences, namely healthcare professionals, women ages 65 and over, those 35 to 45, and then adjacent health issues such as bone health, eating disorders, and dementia. At this point, I'm going to turn it over to my colleague, Gage Dalton.
Thank you, Beth. As she said, our goal for this campaign is to increase awareness of sarcopenia as a health issue and how to address it in the lives of women across the country. We want to equip both patients and providers with the tools and knowledge to overcome the muscle loss associated with sarcopenia. So with this in mind, we developed key messages for both women and their providers with vital information to recognize and address sarcopenia. These are being shared throughout all materials sent out as part of the Stronger Than Sarcopenia campaign. For women aged 65 and older, we want them to know that the loss of muscle mass and strength from sarcopenia can cause difficulty in standing up or walking, which can lead to falls, fractures, fatigue, and loss of independence. And many different factors can contribute to sarcopenia, including changes associated with aging, physical inactivity, poor nutrition, and certain diseases and conditions. A key message is that it is never too late to regain muscle strength. Sarcopenia can be addressed at any age and in any condition, and muscle strengthening and resistance training combined with a healthy, balanced diet not only help prevent sarcopenia, it can also help retain or regain muscle strength that was lost. Then, for younger women, since muscle loss starts in their 30s, they can start adopting behaviors like strength training and a healthy diet to prevent sarcopenia in their own lives, as well as looking out for the signs of sarcopenia in their loved ones. In addition to promoting awareness to the general public, we are conveying to healthcare professionals that sarcopenia is important to address in their patients. In 2016, sarcopenia was assigned an ICD code as a clinical disease for diagnosis, which allows it to be treated as an insured condition. While there isn't a gold standard for the screening of sarcopenia, the most common early screening tool used for both research and clinical practice is the SARCF. The SARCF screening test is a questionnaire developed to assess ability with strength, walking, standing when seated, climbing stairs, and risk of or experienced falls. And our first major outreach to providers has been through a peer-reviewed and accredited continuing medical education, or CME, curriculum about sarcopenia that OWH and Medscape designed together. The Medscape CME module covers the screening, evaluation, treatment, and management of sarcopenia. And the aim is to improve clinician ability to prevent sarcopenia, identify sarcopenia early in the condition process, and effectively manage patients with sarcopenia. Learning objectives for the curriculum include increasing knowledge of the impact of sarcopenia on patient quality of life, and increasing the ability of providers to identify, prevent, and treat sarcopenia. Early recognition and intervention are key to improving outcomes for those with sarcopenia. So screening patients to assess their physical function and activities of daily living should be a routine part of healthcare visits for older adults. And we hope that these messages and the general increased awareness of sarcopenia resulting from the campaign will lead to improved rates of screening, treatment, and management of sarcopenia, encouraging at-risk women to discuss sarcopenia with their providers, and the adoption of positive dietary and exercise behaviors that can combat the issue in older populations. So the Stronger Than Sarcopenia campaign officially launched in August at womenshealth.gov/sarcopenia. The website includes free research resources, posters that can be hung in providers' offices, infographics, and a social media toolkit for those who would like to help with the spread of information about sarcopenia and the campaign. On this slide, you can see an example of one of the free resources available on the campaign website. It can be used by both women and healthcare professionals for general information about sarcopenia and what can be done to improve strength. Then the Medscape CME curriculum I mentioned previously has already been used by thousands of providers who are increasing their awareness of sarcopenia. We are thrilled with the potential change in screening and treatment that will result from it. In addition to those free resources, we've had a strong media outreach to mark the launch of the campaign. This included a press release, audio news release, and social media posts that have reached millions of people across the United States so far, driving each towards resources and curriculum available on the campaign website. We aim to continue with our media and social media presence as the campaign continues to move forward and develop more resources. And on the next slide, you can see the branding we are using for the campaign. It encourages women that they are stronger than sarcopenia by demonstrating what they can do to prevent and address the issue in their own lives. Then on the next slide, you can see examples of the various products that have been developed as part of the campaign already, all of which are available on the campaign website at womenshealth.gov/sarcopenia. Some examples here are a poster on the left that can be hung at provider's office that helps providers discuss with their patients if they struggle with any of the criteria on the poster, each of which was included based on the SARC-F screening test. In the middle are some of our sample social media posts, and on the right are more examples of the research resources included on our website. And then on the next slide, we hope you will join us in promoting the Stronger Than Sarcopenia campaign as we move forward. And thank you again for this opportunity to present on it and discuss some of the overlap between it and bone health. We do have additional areas we are expanding in the coming year, including intersections with sarcopenia, such as bone health and eating disorders. And we would welcome your input into these areas or others as we move forward. And for anyone who is interested in coming alongside OWH and spreading the reach of the Stronger Than Sarcopenia campaign, here's information on how to become a women's health champion. More details can be found at our website at womenshealth.gov. Please let us know if you have any questions about this or the campaign in general. Thank you.
Thank you both so much. It's great to see this. And I do see a comment in the chat giving you kudos for the Sarcopenia campaign. So thank you all for what you do. I'd now like to move into the Q&A portion. We've had a lot of great questions come in. So I invite our panelists to come back and to put their cameras back on and turn off their mics so we can engage in this Q&A. I guess the first question, and this came up in the chat, is how do your agencies work together throughout the year, and how do you specifically engage with each other on bone health? The work is so complementary. We've seen it here, but how do you all work together throughout the year to make sure that you're sharing information and really collaborating on initiatives? And anyone can just jump in here.
I'll take a stab at it. So unfortunately, Lindsay, at least to my knowledge, there hasn't been much, at least with CMS, collaboration on bone health specifically. We do collaborate on other medical conditions. For example, as you can imagine, COVID was quite important, and we worked closely with CDC and AHRQ and some of the other federal agencies in developing recommendations and quality metrics around COVID vaccination. It's going to sound like a terrible excuse, but unfortunately, it's always the most important or acute thing that rises to the top, and that certainly has occupied a good bit of our time up until the past 6 months, I'd say.
Thank you, Dr. Joseph.
Yeah, so for NIH, it really depends on the topic of interest and what sort of research gaps we're trying to fill. As I showed in one of the slides, we were very much interested in the decline in drug treatments for osteoporosis. And so when we started thinking about it, we reached out to a couple of federal agencies to let them know we were interested in doing this workshop. And a couple of agencies signed on, HRQ, the VA. And we organized the workshop, and then after the workshop, we all get together and try to have a strategic plan going forward. And so then depending on which, either the lowest hanging fruit or whichever idea pops to the top, we then invite agencies who want to work with us to put out an announcement for that project. So it all depends.
Thank you. Dr. Peterson?
Yeah, thanks. I think a lot of the work that we do collaboratively with the other federal agencies may not specifically call out bone health as the primary reason we're getting together. But if you think about the groups we have that get together for nutrition and physical activity, for me, that's all related to bone health. So the White House strategy on hunger, nutrition, and health that was released last September is a guiding light for all federal agencies under the U.S. government, all hands on deck to improve nutrition and reduce hunger. It's very visionary, but again, any of those improvements through the White House strategy on hunger, nutrition, and health that were released are going to improve bone health, and it takes a life course perspective. And that work crosses NIH, FDA, HHS. I mean, we've CMS, everybody's at the table on that. The two other things that we have in DMPA that again are in collaboration with USDA, FDA, and NIH, and many other philanthropic partners are our research network. So we have one around nutrition, and we also have one around physical activity. So they're NOPRIN and PAPRIN. So NOPRIN is the Nutrition and Obesity Policy Research and Evaluation Network, and PAPRIN is the Physical Activity Policy Research and Evaluation Research Network. Those groups are all out working to combine assets, and I mean expertise, not necessarily money, around how to drive the research in this country to answer the really hard questions, and again, take that life course perspective. And again, because those federal agencies are all at that table, it's all collaboratively. And I love the question because people don't think we ever work together, and we work together all the time, and we're so busy that we sometimes don't remember to tell everybody that we're working together. So thank you for the question. And for the researcher that asked a question, NOPRIN and PAPRIN will be a great way for you to get to know the research community in both nutrition and physical activity. Over. Thank you.
Thank you. Mr. Dalton?
Right, and just as Dr. Peterson said, anything touching on physical activity and nutrition is important for bone health. And for the Sarcopenia campaign, that's been doubly true as we're focusing on muscle health there. And since we've launched the campaign now, we are looking to move forward in spreading tools and resources, not only for the general public, but for other federal agencies as well, and are looking to start giving presentations and other resource kits specifically to federal agencies so they can reach their populations they're treating and providing care for with the resources that we're creating for the Sarcopenia campaign. So thank you.
Thank you. I'm keeping an eye on the time. I promised our panelists I would try and have them out as close to noon as possible. I have a couple last minute questions, and if you need to go to any of our panelists, please know how much we appreciate you all being here. Dr. Peterson, one question for you. So we know from our work in this space, and you actually alluded to it in your last response, but we know how important diet and exercise are in supporting bone mineral density throughout the lifespan. But I think there's often a disconnect. So what do you think that there's more that we can do to connect those dots for members of the public, or how might we improve our messaging there to really make the case that diet and exercise have a direct impact on bone health?
Yeah, I think reiterating what you just said a million times, a million different ways. And that's why our Moving Matter campaign also is important that you can get off of our website. I think HHS is doing a very good job about that as well, continuing to message across all of HHS with the partners. I do think that the dietary guidelines for Americans and the physical activity guidelines, Americans are not aware of those. And so I think sometimes they think we're all working randomly and doing all the things that we just want to do, where actually there's a whole scientific body of evidence in both nutrition and physical activity for what we need to do to improve everybody's health and make bone health a critical thing that people think of. Like when you think of well-being and when you think of reducing healthcare costs and quality of life, we just need to remind people, just like I need to remind people obesity is a chronic disease, we need to remind people that bone health is critical for people's productivity and functioning and reducing healthcare costs and well-being, and just say it 1,000 ways.
Thank you so much. You're right. That's so important. Dr. Joseph, did you have something?
Yeah, and just to follow up on what Dr. Peterson just said in terms of physical activity and nutrition, from the research perspective, it is so important to really think about that as we go through our life, daily activities. Because one of the things that it does in, people, I just look at things in isolation, bone, muscle, fat. But the more active you are, the better diet you have, the better health you have, the crosstalk between these tissues, bone and muscle, bone and fat, the efficiency improves, and it really results in a lot of benefits, overall health benefits for the individual. And she says people don't think about bone because you really don't see it. From a physical perspective, you see the muscle, you see the fat, but you don't think about bone. But it is very, very important to have proper bone health because of compounds that are released from the bone that could affect other tissues as well, and not only the muscle and fat, but also the cardiovascular system and the vascular system as well.
So important. Thank you. Thank you for raising that. Dr. Green, a question for you. So SWHR has been really supportive of the efforts of the Bone Health and Osteoporosis Foundation and the American Society of Bone and Mineral Research to get CMS to add a G code for fracture liaison services for osteoporosis and bone health care. And I saw a question about this within the chat as well. I know career staff at CMS have been very supportive of this, but is there something more that we could do or information we could provide to really prioritize this?
Yeah, I saw that in the chat. That's a great question. Unfortunately, I don't work on coverage, but one thing that did occur to me on something we do work on is in the MIPS program, the measure-based incentive program that I was mentioning, improvement activities are one category, and it accounts for about 10 to 15% of a clinician's score. This would be something that could be proposed, if someone wants to propose it to us as an improvement activity. So in other words, they offer at least those services. Again, I understand the coverage is an issue, but our program is not only Medicare Benny related. I mean, we accept all payer data. So that is something that could be considered at least as a way. Again, it won't be covered, but it would be an activity that would be recognized as being important. And again, the more publicity it gets, if you will, the better the chance potentially, especially if the science is there, of course, for coverage.
Thank you so much. That's great. And I know I've kept you a few minutes over, but just for closing thoughts, we have this event. So we have, members, congressional staff, members of the public, members of nonprofit and voluntary health associations online. What is one thing that you would hope people viewing this webinar today would take away from the discussion? And maybe we can go in the order in which you presented today. So we'll do Dr. Joseph, Dr. Peterson, Dr. Green, and with our HHS colleagues.
I think it's to echo what both Dr. Dalton and Dr. Peterson have talked about, is that thinking about being physically active, maintaining quality muscle mass also will result in maintaining quality bone health. And so being physically active, proper nutrition, it goes a long way improving the overall health of individuals across the lifespan, not just all individuals, but across the lifespan. So being physically active, be aware of that, and try to get the recommendations, at least the minimum exercise recommendations, and follow the dietary guidelines as close as you can.
I think it's well stated, and I would just add, we have so much work to do, and we should all do it together. And so rebuilding the wheel is not necessary. So just oversharing and over communicating and having groups that work together to make improvements in overall health, including bone health. Over.
I guess that might be me. So I guess my thoughts would be, really publicizing and making the clinicians and patients aware of the problem. I mean, unfortunately, I don't say it's swept under the carpet, but people are, oh, I got to get my blood pressure under control, which is extremely important. But just like blood pressure doesn't usually kill a person in one day, it's a lifelong process. Same thing with osteoporosis. It's not going to necessarily do you in today, but certainly in the future could have a significant impact on your health. So unfortunately, the condition is underdiagnosed. We need to stress the importance of prevention because of the devastating potential effects if someone does unfortunately suffer a fracture. So I guess elevating it from a publicity standpoint, I think would be beneficial.
I'll add that so many of these conditions, particularly with the use of physical activity and nutrition and non-pharmaceutical events or treatments, can really give some control back to the patient, and that instead of things happening to them, that in fact they can have some control about improving their health, and it can make some significant differences, and they can do it themselves. That sense of agency, I think, is very important for all people, and particularly women.
And I'll just end on, it's never too early or too late to start making those changes. Any dietary or physical activity behaviors that you're adopting now are helping your health in the long run and improving that strength that's going to prevent falls and fractures down the road.
It's a perfect way to wrap up, Gage. I would like to thank our panelists for joining us this morning. I think each of your presentations was really reflective of how complementary the work you all are doing is in improving women's bone health across the lifespan. Thank you for your efforts day in and day out. We know what an undertaking it is. There's still more work to do, but you all are really helping propel us forward as a society. Again, thank you for contributing your time and expertise today. And again, as a reminder to our audience, this event will be recorded and posted online. So please feel free to share it widely with anyone that you think may be interested in this content. Again, thank you all for joining us, and we will be in touch soon.